diabetic nephropathy is so difficult and so extensive, we just scan through various things we can, learn from the different categories or different classes of medications that we have. I think quite a number of the slides which I show probably have been going through. The global prevalence of diabetes is on the increase. And in Kenya, we have about 3.1 going to 4.6 in the last 18, 15 years. And the associated major devastating complications out of diabetes. One being kidney disease and kidney failure, which we are looking at as diabetic nephropathy or diabetic kidney disease. Diabetic kidney disease is associated with high morbidity and mortality, and actually is the leading cause of end-stage kidney disease worldwide. Talking about burden, nephropathy is the strongest predictor of mortality in patients with diabetes. Any other complication they have may not predict. So if you've got a patient with diabetes and they get nephropathy, it's a major predictor for their death. The worrying thing is that despite all what we have put in the last 20 years, the intensive and what they control glycemic, hypertension, the RAS blockade, and so on, the prevalence of diabetic nephropathy has not changed. And this is of concern. Diabetic kidney disease increases your risk of death by 6-fold. The issue is that most of these people will not even come to you for dialysis. 90% tend to die before they require renal replacement therapy. That tells you how devastating the cardiovascular side effects or complications of diabetic nephropathy are. Now, in our setups, the risk of death increases if you get on to dialysis. But we know that depending on the country and the region you are, only about 10 to 50% of our patients who need dialysis actually get it or get it well done. So it is a disaster and it's a major public health concern. Maybe we've gone. When trying to translate knowledge into practice, into what to do, there's lots and lots of wealth of knowledge, but there are many things that will help us determine. We got to know the environment you're operating at. You got to know the kind of patient. I think the previous speakers have talked about, and we also cannot in any way come out of the fact that diabetic kidney disease or even CKD is a public health, concern. So our approach to management in every country should have a look at all that. Early diagnosis and treatment is definitely, as has been said, prevents the onset of diabetic nephropathy, but they reduce but do not eliminate the risk of developing diabetic kidney disease. Now we look at the goals, which the cornerstone, which is intensive glycemic control. We've had a talk on that in the last speak. And these are the 4 pillars which we all know, and they're not there's no controversy about that. Intensive glycemic control, intensive hypertensive treatment. The only thing which I put in bracket there is that probably once in a while we forget salt as a major factor in the control of hypertension in our patients, and that needs to be looked at. The widespread use of the RAS blockade, and I added in my brackets there that the consideration for the use of mineralocorticoid receptor antagonists. Lipid modifying therapies, these are the 4 which are well known. But there's a need to reevaluate the newer and even older medication in the light of what you know about diabetic kidney disease. And this means we've got to really focus as we look at each agent, especially on agents that ameliorate the cardiovascular disease menace, and that means morbidity, cardiovascular death, and all-cause mortality, which is actually increased in patients with diabetic kidney disease. And that's how you make your decision. What I think this has been done, Dr. Berger looked at. If you're looking at a patient, then these are the main things which a nephrologist looks at. We talk about weights, profiles, and metabolic profiles of a product, the potential to induce hypoglycemia, what are the renal outcomes in this product, what is the relative ease of use in CKD. We know if you got CKD, there are disturbances in your pharmacokinetics, pharmacodynamics, and so on, and interactions of a patient who is having on board multiple medications. These have got to be put in consideration when you're choosing the products to be used. The ease of use by patient, that addresses issues like psychological resistance to insulin. Anytime you want to, or injectable medications, and they may not be willing to take an injectable medication just because psychologically they're not prepared for it, and we don't have much time to prepare our patients. The effectiveness of glycemic control, the other side effects, and of course, public health decisions. I'll run through the various classes because they've been already introduced. The sodium glucose cotransporter 2 inhibitors, the mechanism has been talked about. The recommendation has been before the credence studies has been to avoid below GFR 45, but probably now we could reduce up to 30 to avoid adverse effects. Yes, from the studies of the EMPA-REG outcome, the canvas, the credence, we know that we have benefits both in cardiovascular disease and chronic kidney disease. Now, the initial studies before credence where the endpoints, the primary endpoints were cardiovascular, but credence had renal outcomes as being primary endpoints, and we had patients with established nephropathy. So it's a real, we see that we have cardio and renal protective benefits, reduction in albuminuria, and a 32 to 34 reduction of renal-specific composites. That's end-stage kidney disease, transplantation, and renal-related death. The improvement in cardiovascular and chronic kidney disease outcomes, especially in patients at high risk. So that's the class which we have to watch and probably think of putting on board in our patients. Probably the costs and other things may be an issue. Now, the trials have taken patients with GFRs above 30. We don't yet know what the effects is below GFR 30. And most of us in practice, by the time most of our patients, probably 60% of patients from research done in this country, come to the nephrologist when their GFR is below 30. So they come when probably we cannot really use these very important and well-proven medications. We've got to be careful about malnourished individuals, the elderly, and those who have restrictions, because large loss of glucose may be detrimental to their health. That's energy loss. And there's a risk of diabetic ketoacidosis, so we can't use them in type 1 diabetic nephropathy. The next, about the new ones which they're already in circulation, and the DPP-4 inhibitors. Mechanism is that they prevent degradation of incretin hormone by the DP4 enzyme. And in the long run, you get an enhanced glucose-dependent insulin secretion. Now, because of that, they're not, they're very gentle. They don't induce hypoglycemia, which we know is a major problem in patients with diabetic nephropathy. We have a number of agents, and they are oral, so they are, most of our patients with type 2 would not mind using DPP-4s, and usually once daily, and you don't need to take them roundabout meals because they're kind to hypoglycemia. But each DPP-4 inhibitor is different. They've got different pharmacological properties, metabolism, and excretion. Now, that's one factor which is so important in practice, in that you've got to really think about your medication, how is it cleared, and so on. And it takes a lot of time for those agents that need to be thought through. And probably in the whole of that list, it probably ends up with the probably linagliptin having the easiest profile to use because of its limited renal excretion, which is about just 5%, and they can be used right through to end-stage renal disease. As I said, they cause minimal hypoglycemia. They've got they're weight neutral, and they can be used as add-ons to sulfonylureas, glucophage, which is and to insulin. But if they act as add-on, that increases the risk for hypoglycemia. But they've been allowed as monotherapy by the FDA. They've got independent renal and cardioprotective effects, as we've heard from different studies. And there were initially some concerns about cardiovascular safety, but these concerns probably cannot be sustained after Carolina, which was a 6-year overall safety follow-up for linagliptin, and the Camelina, which was a 2-year follow-up for older patients with severe CKD. So they've got a reassuring cardiac and renal safety profile. The other class which we probably coming up and also has not been on the front line to most of the public kind of practice in Africa are the GLP-1 receptor agonists. They mimic the gut hormone known as incretin and stimulate insulin release. They increase, they reduce appetite, they reduce your weight, and but they are injectable agents, and we got them in circulation already. I think the one which we have is the liraglutide, and there's some complications around them, pancreatitis. They got more nausea, which could probably limit their usage. Now, liraglutide, which goes around as Victoza, reduced death by cardiovascular disease, non-fatal by myocardial infarcts, non-fatal strokes by 13%. But there are increased gastrointestinal side effects, and when you compare them to DPP-4s, probably DPP-4s tend to have less gastrointestinal side effects and tend to be more acceptable because they are oral. But their meta-analysis of large cardiovascular outcome, the ELIXIR, EXCEL, the LEADER, the SUSTAIN 6, which have been talked about in the last talk, all of them initially, the primary outcomes have been more cardiovascular, and GLP-1 receptor agonists have got a reduction in major cardiovascular events. They also prevent the onset of proteinuria. They reduce the decline of glomerular filtration rate. That is, they slow down the progression of CKD. and there have been improved renal biomarkers with GLP-1 receptor agonists. Liraglutide has been associated with reduction in mesangial expansion, increase in glomerular nitric oxide, and improvement in glomerular hyperfiltration. Now, all these effects are independent of glucose-lowering effects. So the first three classes, not common, but probably on board. The DPP-4s are around with us. The SGLTs too, coming really on board. The the glucagon peptide-like 1 receptor agonists still around, but not. So they have proven cardiovascular, safety and beneficial effects. They have renal protection. But if you look at the ones which are probably established public health use, the bioguanides, and that is metformin, which stands out. They increase insulin sensitivity and decrease hepatic gluconeogenesis. And there's no association with hypoglycemia. They've got a good weight profile, and they are effective, okay? So these are with us. It's cheap product. There was, of course, concern initially about lactic acidosis, which is actually rare and seems to be in situations like where you got hypertension, myocardial infarct, and nephrotoxic agents on board. So the fear for lactic acidosis is probably not as much as it was put. But of course, we've got to be careful with them, and there are guidelines on how to vary the dose. But below a GFR of 30, we should avoid. But the first-line medication in the treatment of type 2 diabetes, and there are some meta-analysis of 17 observational studies, and we know that they've got pleiotropic actions beyond glucose control. In the UKPDS, metformin reduced the risk of any diabetic endpoint by 36%. And that means blindness, hyperglycemia, severe kidney failure, and amputation. It did better than insulin and even sulfonylureas in that respect. They've got favorable effects on blood pressure, lipid profiles, metabolic control, and albumin excretion. Metformin reduces interstitial fibrosis and probably protects GFR and improves survival in CKD patients. The no problem, probably is widely used. All these studies are observational, and probably we need random controlled trials for that medication. Sulfonylureas, which we use quite a lot, very effective. The problem in diabetic kidney disease is the induction of hypoglycemia, especially with declining GFRs. Now they've got second, third generations, fourth, and so on, and they're very difficult to use. Almost all their metabolites are renally cleared, and that increases the risk of hypoglycemia. The renoprotective effects of sulfonylureas got some reports looking about glomerular protection, and so on, but they're not established, and generally really inferior to metformin. They may aggravate obesity, dyslipidemia, arterial hypertension, and thus their cardiovascular outcomes are probably inferior. And probably this is the class to think about promotion in our setup, whether we should really or be very selective on what we may select among the sulfonylureas, because they may be able to control your glycemia, but may not protect your patient around the cardiovascular and renal chronic kidney disease outcomes. Insulin with us, it's allowed, you can use insulin through all the stages of diabetic kidney disease and all stages of CKD. But about 30 to 80% of endogenous insulin is eliminated by the kidney. And if you inject it, it's virtually removed by the kidneys. The risk of hypoglycemia is quite a major issue. Of course, the issue for type 2 diabetics who have been taking oral agents is that they resist starting insulin, injectable insulin, so there's resistance to that. Now, hypoglycemia is an issue, as I said, and you got to be careful. But there are many variations, the long-acting insulins, the basal insulins, the short-acting, so there's a lot to pick from. The results on the cardio and renal protective effects of insulin are mixed. We know tight control may have beneficial effects, especially if in the early stages or in type 1 diabetes and patients who are younger, where you can easily tightly control. The danger of hypoglycemia is real, and they may, in patients who are tightly controlled, because they get episodes close to hypoglycemia, it may end up augmenting or aggravating obesity, dyslipidemia, and arterial hypertension. And that may make insulin difficult as far as cardiovascular outcomes are concerned. It may be difficult in our patients who are not followed up, who are not able to monitor themselves as frequently as they would like them to. And we've got to find its place at the public health level in patients with chronic kidney disease. So the others will not. So that's what the jury has got to consider, especially in our setup. How are we going to make our decisions? The typical patient who comes to me is a retired 60-year-old type 2 diabetic with retinopathy, has got a myocardial infarct, is on dialysis, probably is in stage 3, 4 going on, has got peripheral vascular disease, is coming and maintained by the children on handouts every month. And these are the patients we have to decide how to manage in tropical Africa. And probably the hope is that when we've got such wealth of knowledge and good products around us, what is feasible, what can we recommend in our setups, and what can be probably afforded by our environment and our governments. Thank you. I think that's the last slide.